Hello and welcome to this Improvement Science Snapshot. My name's Dr. Helen Smith and I'm a Senior Research Fellow in the Yorkshire and Humber Applied Research Collaboration. And I'm pleased to present this snapshot on co-production of applied health research. Before I delve into the detail of co-production, I just wanted to say a bit about the context. So firstly, patient and public involvement has become increasingly important in health research. The definition adopted by the NIHR is for research to be undertaken with or by patients and the public rather than on or about them. And secondly, while there's evidence that PPI does improve research, there are many barriers to it becoming truly embedded and criticisms of tokenism in how it's been used. And a strategic review of public involvement in research conducted in 2015 suggested that co-production could be a way of improving and evolving public involvement in research. So the NIHR defines co-production as an approach where researchers, practitioners, and the public work together, sharing power and responsibility from the start to the end of a research project. A key feature is sharing of power and decisions. Also, the relationships between researchers, the public, and practitioners need to be valued and nurtured and maintained, and everyone should benefit from working together. This concept of co-production has a long history and seemed to originate in the 70s with the work of Elinor Ostrom, and more recently it's been applied in mental health and social care as a way of service users working in partnership with professionals. So now I'll talk a little about applied health research and how it can be co-produced. And by applied health research, I mean research that's directed towards evaluating quality and safety, or developing and evaluating healthcare interventions or technologies, or understanding implementation of evidence-based interventions. And despite the abundance of frameworks and guidelines and principles, there's not much empirical knowledge on how to co-produce research. And some authors have pointed out it's not always clear what's being co-produced, how, and by whom. However, there does appear to be consensus that any or all steps of the research process can be co-produced. And the image here shows the different stages of evidence production and compares the traditional approach to the equivalent steps for co-producing evidence. And the way that co-production is operationalized will typically vary depending on the purpose of the project, what's being co-produced and by whom. And the NIHR guidance acknowledges that some people may want to co-produce just parts of the process, and in other circumstances, co-producing the entire research project might be appropriate. So we have recently conducted a scoping review of co-production practice and research priorities in UK-funded applied health research. And our review included 19 articles reporting co-produced complex interventions and 64 reporting co-production in applied health research. And a key finding was how co-production had been conceptualized. So firstly, co-production was the most widely used term, and it referred to the involvement of various stakeholders, groups in multiple stages of the research process. And the concept of shared power was often used when describing co-production. Co-design, on the other hand, was used to refer to stakeholder involvement in the design process of tools, interventions, or initiatives across a range of specialties. And emphasis was placed on the value of experts by experience and what they can bring to the design process as equal partners. Co-creation and co-production appear to be very, very similar, but co-creation seems to represent a more prolonged engagement and involvement of stakeholders in all aspects of the project. And where it was possible in our review to identify how co-production was enacted, the activities reported in the papers included things like interviews, group workshops, focus group discussions, social media forums, or a mix of all of these activities. The scoping review also identified lessons for the practice of co-production, and I just want to share a few of those with you. The capacity to implement co-produced interventions was thought to be important, and the included papers emphasised building capacity to adapt and absorb the changes that had been brought about through co-production, and having a cadre of implementation savvy researchers who can actually do implementation was considered vital, as was having frontline staff who can act as agents of change. The skill set for co-production was also emphasised, and the skills required of researchers for co-production might often lie outside of the typical academic skill set. So, for example, collaborating with diverse stakeholders, negotiation skills, managing expectations, and prolonged involvement with stakeholder groups. There was also recognition that not everything has to be co-produced and not everyone will want to occupy this space. Thirdly, multiple levels of engagement and negotiation. The papers highlighted the importance of bringing together stakeholders with different experiences and perspectives and values, but it was thought to require leadership and careful negotiation of group politics for meaningful and productive discussions. And finally, funding and institutional arrangements. The main concerns here were the need for sufficient funding for co-production activities that really ensure inclusivity, diversity, and equality. And it was also recognised that effective co-production is going to require change in academic institutions and scientific practice to embrace more equal power distribution in the process and also ensure proper governance of co-production. So I've given you an overview of co-production in applied health research. I hope it's been of interest, and please do look out for more snapshots in the series. Thanks for listening.